Good afternoon.
Still mute.
It's a pleasure to be here at the Citrus Research Exchange Seminar, and it is, thank you very much, it is a webcast, so let me do all the housekeeping that I'm supposed to do before we introduce the speaker. So, let's see. So, introduce yourself. That's me, Shankar Sastry. I'm the Dean of Engineering here. Welcome everybody on the web. I know it's being broadcast to all the Citrus campuses and beyond as well. I've been at these seminars where we've been seeing questions come from all over the world, so it's pleasant to see that people are listening to it. Then I'm supposed to say that please recycle and compost in the bins. This means please eat lunch too. I think we're serving lunch in the back there. The next talk in this series is by Geron Lanier on Monday, October 14th at 11 a.m. Geron Lanier is, one of the pioneers of telepresence and virtual reality and all of that, but his talk is called "How Can We Prevent Information Technology from Destroying the Middle Class?" So that should be intriguing, and those of you that know him will know that he'll give you an intriguing talk. And finally, this is one that's close to my heart. The Big Ideas competition is open. There's a Citrus Big Ideas competition. Pre-proposals are due November 4th. And then, there's one round of evaluation. There's full proposals and so on and so forth. So we invite everybody to send in proposals to the Big Ideas. I think Yvette is the person that receives them. Okay, today it is a great pleasure to introduce Susan Lim. Anyone who's observed robotic surgical procedure can't help but be amazed by the remarkable technology that's in the hand of skilled surgeons today. And actually, in today's San Francisco Chronicle, in the business section, there was, all these 3D printed organs that Paul Wong at Stanford has been thinking about, and I don't know how many of you have had a chance to see it. But in any case, with all of this, both surgeons and engineers know that we've just scratched the surface of optimizing surgical robotics and unleashing their full potential. Dr. Susan Lim is an authority in this field, a surgeon with a vision for the future of surgical robotics. A native of Singapore, she performed Asia's first liver transplant there in 1990, pioneered a widely used minimally invasive breast biopsy procedure, and has been a leader in advancing programs for robotic general surgery in the US, Europe, and in Asia. She graduated from Australia's Monash University, obtained her fellowship at the Royal College of Surgeons in Edinburgh, and a PhD in transplantation immunology at the University of Cambridge. In 1990, she returned to Singapore to join the surgery faculty of the National University Hospital. She also has a deep interest in stem cell research and is the founder of Stem Cell Technologies, a biotech company. She serves on the Global Advisory Council of the International Society of Stem Cell Research. She continues to be very active in research and education and has generated a continuing buzz of interest, especially recently with her 2011 TED Talk called Transplanting Cells, Not Organs. She's also a great friend of Berkeley, I have to say. She has entrusted her daughter to this institution, so I know she's in the audience also, so welcome. And we are delighted that she's joining us here as a visiting scholar in the EECS department, and she is here to speak on robotic surgery, a step beyond. Please welcome Dr. Susan Lim.
Thank you. So, thank you very much, Dean Sastry and the organizers, for the invitation to speak at this Research Exchange Seminar series sponsored by Citrus. Today I'm going to speak on robotic surgery, engineering from a surgical perspective. It's really been a fascinating experience for me to have trained in the three eras of modern surgery. First, learning how to make big and wide enough incisions, large enough for the surgeon's hands to enter the abdomen, and then transitioning to making keyhole punctures small enough to admit 10 millimeter instruments and surgical cameras. And then just barely a decade later, to have the opportunity to train and also to pioneer a robotic general surgical program in my country. Today, robotic surgery, as Dean Shankar Sastry has said, is still very much in its infancy. But already, worldwide to date, 1.5 million robotic surgical procedures have been performed. And in the last year, 400,000 robotic surgeries have been performed in the US alone. So the transition from open to robotic surgery has taken the surgeon from being by the side of the patient to being away from the patient, and from having been limited to one's own limited capabilities of vision and dexterity, to then being enhanced by being seated in a console like a pilot in a cockpit, with a view of the operative field which is 10 times magnified and in 3D. And I'm not sure if this pointer is working. But the surgeon uses master controls, which then position telemanipulators, as shown here. And the telemanipulators then hold on to robotic instruments to enable the surgeon to perform the surgery. So the application of robotic surgery is very much a partnership between man and machine, each complementing the other to perform a task better than either can do alone.
Yes, a point.
Oh, thank you. So robotic surgery had its origins in a single-armed robot called ESOP in 1994. And the role of ESOP was simply to hold on to a surgical endoscope to provide a view into the body cavities. And ESOP was controlled and responded to the voice commands of the surgeon. Now, the company that made ESOP, Computer Motion Industries, went on to produce Zeus, a 3-armed surgical robot driven by the surgeon in the control seats, and which received FDA approval in 2001. And for a short period of time, telesurgery was made possible using the Zeus platform. And in 2001, Professor Jacques Marescot made surgical history by performing the first transcontinental, transatlantic robotic surgery procedure on a patient in Strasbourg, France, whilst the professor was seated in a console in a hospital in New York. And this feat was made possible by the cooperation and the efforts of a team of academic and private engineers, proving that distance was no longer an obstacle in surgery. Now, around the same time, another company, Intuitive Surgical, produced the Da Vinci robot. And following a merger of Intuitive Surgical with Computer Motion Industries, the Zeus robot and its telesurgery platform was discontinued. And today, we have the Da Vinci robot surgical system as the state-of-the-art system for use in soft tissue surgery. And indeed, the Da Vinci has been used to perform a whole wide range of surgeries in the disciplines of general surgery, cardiothoracic, urology, and gynecology. I think Intuitive Surgical has had just such a phenomenal and successful run that today almost 1 in 4 hospitals across the US has a Da Vinci system, or at least one Da Vinci system. So that the Da Vinci robotic system has 4 main components: a console or surgical workstation, a patient side cart which houses the robotic arms, a vision system comprising the high definition 3D endoscope and image processing equipment, and endowrist instruments named after a human wrist. The 4 robotic arms enable solo surgery for the surgeon. though in reality, robotic surgery is really a team effort. One of the robotic arms holds on to the camera for stability, and there is fingertip control, motion scaling, filtration of tremor, intuitive movements, and for the robotic instruments, 7 degrees of freedom of movement and 90 degrees of articulation. And with motion scaling, the coarse movements of the surgeon's hands can be reduced to much finer movements, enabling surgeries to be performed in deep recesses of the human body. The endo-wrist instruments comprise both mechanical instruments such as graspers, scissors, and needle drivers, as well as advanced energy instruments, the monopolar and bipolar cautery, harmonics, and the laser. And these instruments are used to help the surgeon to dissect, to tissue manipulate, to cut, and to coagulate. And so I'm going to show you a snippet of a few clips from robotic procedures done in my practice. And this first scene shows the surgeon seated at the console, immersed in an operative view, though at the top the flat screen is the only view available to the assistants. And the assistants really are seated by the table to assist with instrument change. This is the training surgery for general surgeons, which is a robotic cholecystectomy or removal of the gallbladder. And this just serves to show you robotic instruments at work. On the left, a grasper, a fenestrated grasper, and on the right, a monopolar advanced energy instrument, which is the hook. And you can see that with the wristed instruments, one is able to encircle structures, and this is the cystic duct, which connects the gallbladder to the bile duct. And this is a pair of robotic scissors dividing the cystic duct between surgical clips. And then the gallbladder is removed from the liver bed using monopolar cautery, in this case a hook. And then a change of instruments by the assisting team. And now we are looking into the pelvis. This is an abdominal approach for repair of an inguinal hernia. And here we have the fenestrated graspers and a monopolar energy instrument, the spade this time, it's a spade. And what we're doing is gaining access to expose the hernia orifice, which is just coming into view. There is the hernia. And then a mesh is placed over the hernia to occlude it and stapled into position. This is not a robotic instrument. You can see how rigid it is. It's simply a clip applier to staple the mesh in position. And then the peritoneum is sutured over the mesh to exclude it from the abdominal cavity. And here you can see the wristed movements of the needle drivers and how it is made very easy suturing for a surgeon laparoscopically. And here again, the surgeon seated in the console with the arms rested on armrests. And this time, suturing in a more delicate area between the liver and the duodenum. This is an anastomosis, a joining together of the bile duct and the duodenum. And just now you saw some water squishing in. That was done by the assistant surgeon using a laparoscopic pot. So it's pretty much a mix and a match. Even though you're doing robotic surgery, you sometimes need to bring in additional laparoscopic equipment. Robotic surgery is very good for dissecting in deep recesses, particularly if one needs to identify fine structures such as nerves and blood vessels. Robotic surgery is really excellent in providing a great view, and that was a view of the axilla in a patient with breast cancer. A change of instruments again on the outside, and this time we look toward the pelvis. This is a colon dissection. This is the important step of first identifying the ureter and then encircling one of the major arteries that need to be divided in order for the colon to be removed. Here again a robotic grasper, a fenestrated grasper, and then in this case we're using a spade to encircle the inferior mesenteric artery, which is divided between clips with the robotic scissors. And then the rectum is then mobilized, freed up, and then divided. And so this is the freeing up of the rectum. And the next clip is an interesting one. This is a dissection into the uterus to extract a fibroid, which is a large tumor. And, sometimes surgeons are very innovative. This tumor obviously is just too large to be handled by the robotic instrument, so we had to bring in a corkscrew to be able to anchor the fibroid and literally yank it out, so to speak. But here it's a very interesting scene. You can see a combination of robotic instruments, laparoscopic and very simple instruments, and here you see the fibroid being mobilized. Obviously this is just far too large to be extracted from a 10 millimeter pod, so it's undergoing morcellation prior to extraction. And then I want to show you a more complex dissection, which is on a patient. This next slide is on a patient who presented with jaundice, and the jaundice was due to a blockage of the common bile duct by a stone. And here you see the robotic scissors making a little nick in the bile duct, which is really grossly dilated, and you can see the immediate gush of bile coming out, and then debris, which is not meant to be. It's not meant to be there, but you can see debris just exuding from the common bile duct. And so what we do is when we extract the debris, rather than pulling it out through the abdomen one at a time, we just improvise and put a simple rubbish bag or sterile plastic bag. It's really quite innovative surgery, if you like. And then we dump the debris into the rubbish bag, and at the end of it all, then pull the rubbish bag through one of the ports. And here we have introduced a fiber optic endoscope to have a visualization into the bile duct to determine where the stone is and how one is going to extract it. So again, this is an interesting scene because although this is robotic surgery, you see the robotic instruments, but this is not a robotic piece of instrument. This is a fiber optic endoscope, and then you see a simple sterile plastic bag and some bits of gauze to soak up the blood. And this last movie clip is to show a robotic dissection of adhesions. And adhesions develop in patients who have had repeat surgeries, usually as a result of trauma or blood loss. And the adhesions are very much like cobwebs sticking organs to each other, sometimes resulting in quite excruciating pain for the patient. So this shows a dissection of the adhesions, and you can see it's quite a tedious task, but extremely doable with robotic surgery. So with robotic surgery, the surgeon is comfortably seated at the console and is able to concentrate for quite long periods of time performing complex surgeries. And it's the surgeon who is completely immersed in a 3D view of the abdominal cavity, but the rest of the surgical team is really confined, limited to a flat screen view of the surgery. And for long procedures, it can really be quite boring for the assistant team, and that's why they're paired up, because they take turns to have coffee breaks. And you can see that really the robotic system, once it is docked in position and sterile surgical drapes are applied to the telemanipulator arms and the instruments, it's very difficult to undock the position in order to move the table. And you might wonder, well, why do we need the operating table to be moved? Well, in regular open surgery, the operating table is moved all the time, up, down, tilted to the left, right, head up, and head down. It's the anesthetist's task, and the surgeon usually does ask the anesthetist to help with positioning of the table. But once the robot is docked in robotic surgery, it is difficult to move the position of the operating table without undocking the robot. So that's one of the limitations. Also, as can be seen here, robotic systems currently are quite big and cumbersome, similar to how digital computers were in the 1980s, and also expensive. So where are we headed to with the next generation of surgical robots? Certainly we need the system to be much smaller. As a patient, it is quite intimidating to lie on the operating table with a hunk of metal hanging over you. Certainly, the footprint needs to be much smaller to enable the robot to be maneuvered within the operating room. And here, enhanced surgical goggles, such as the one here from Sony, would provide the team members with an immersive environment similar to that of the surgeon, so that this would facilitate virtual interaction between the surgeon and the team. The robotic arms, the telemanipulators, need to be miniaturized, and MEMS technology would be suitable to create actuators and sensors which then can be mounted on a robotic hand. And as for the workstation should provide the ability to superimpose pre-operative images onto the operative view in real time, because if this is possible, then the surgeon can plan, the surgeon can rehearse, and the surgeon can create no-fly zones to limit the instruments from straying into dangerous territory, for example, prevent the surgeon from accidentally cutting important structures, such as nerves and blood vessels. So where are we headed? We need, in the not-too-distant future, to take the surgeon to the next level, from looking inside body cavities onto the surface of organs to being able to look inside organs and through organs to what lies beneath, to the cells and the microenvironment. The innovation of robotic equipment requires a multidisciplinary approach combining biology, engineering, and information science to create new biosensors and intelligent robots. For example, we need force sensors to help perform safer surgery, because increased force is associated and is directly correlated with increased tissue trauma. So it is quite important if the surgeon could have a sense of force feedback. Also, to return to the surgeon, a tactile sensation would enable the surgeon then to have a touch and feel sensation. Other parameters that might be quite useful include tissue stiffness and elasticity. We know that tumor tissue is more rigid than normal tissue, and so the ability to discriminate normal from tumor tissue would certainly aid in cancer dissection. And another parameter is vascularity or blood flow. And just on this note, Intuitive Surgical just this past month has come out with a fluorescence imaging vision system, which enables surgeons now to see blood vessels in real time using a fluorescence green dye. And this is taken from the Intuitive Surgical website of a kidney tumor before and after the use of the fluorescence dye. So we face exciting engineering and surgical challenges, but also opportunities to create image-guided subsurface dissection tools, not just real-time sensors and with imaging capabilities, but also advanced and other novel instruments to enable us to operate at this scale and this level. A peep into the future. Robotic surgery has started to make inroads into cell surgery. And for example, the delivery of stem cells has most recently been done in a pig model using a robotic system. But here I'd like to emphasize that all applications in cell surgery are at a research level only. And if I can just show you this animated movie which we made. This shows a heart attack, really, an area of infarcted myocardial tissue. And this is a surgeon from our team in our hospital injecting stem cells into the part of the heart muscle that has been damaged. But of course, this procedure is now able to be performed robotically in an animal model. And the release of stem cells, the stem cells, what they do is they home to damaged tissue and then lead to the repair of the cardiac muscle that has been damaged by the release of growth factors and cytokines, but also maybe through the differentiation of the stem cells into cardiac myocytes. Further downstream, it may be possible to perform cell surgery using femtosecond lasers to access within the cell and to manipulate each of the structures within the cell. And femtosecond lasers are positioned from a workstation pretty much like a surgeon would control telemanipulators from a console. So, but the thing about cellular surgery, of course, it is many thousands smaller in size, in scale, than robotic surgery. And also the next generation of instruments for cancer surgery need to be able to discriminate normal from tumor tissue such that we will be able to target cancer cells. So today, unfortunately, I would say, cancer surgery is still as much an art as it is a science. Now, the principles of cancer surgery to the surgeon are very simple. Simply to remove cancer with a rim of normal tissue surrounding it so that we can minimize the risk of local recurrence. Yet, to achieve the negative surgical margins, the surgeon does not have the ability in real time to determine if the margins are clear under microscopy. So what happens is the surgeon removes the tumor with a rim, let's say 1 centimeter or 2 centimeters of normal tissue, hands it over to the pathologist who performs a frozen section microscopy in the adjacent room, and then 20 to 40 minutes later comes back to say to the surgeon if the margins are clear or not. And if the margins are not clear, then the surgeon needs to return to the operating field. And here then comes the art, because the surgeon will need to reorientate the specimen and determine which margins to remove, how much to remove. So clearly, for the complete eradication of cancer, what we need are smart identification tools in real time and auxiliary confocal microscopy for real-time imaging. And if we have these tools, then we may be able to advance the art of cancer surgery toward a science. So in the evolution of a surgeon, the training has been to be an open surgeon, a laparoscopic surgeon, a robotic surgeon, and a telerobotic surgeon. And in this age of computer-assisted surgery and information science, there needs to be a paradigm shift in the training of surgeons, such that surgeons are now a part of a team of engineers, programmers, and other professionals to design, construct, and also instruct robots. Autonomous robots will soon take over parts of surgery, for example, the more repetitive tasks of suturing. And in the near future, with advances in computer power and artificial intelligence, it may be possible to have miniaturized robots roaming around the body, locating abnormalities, analyzing them, and then removing them without human input. So in the future, robotic surgery is going to be more than just removing and replacing parts of organs. Robotic surgery will also be used to replace damaged tissue and damaged organs with transplants, as in the kidney transplants that are now being performed robotically, but also using bioengineered substitutes. And further into the future, with advances in both computer science and stem cell science, it may be possible to use the robotic platform to regenerate organs using cells and stem cells. So, in conclusion, I think that robotic surgery is still in its infancy. Certainly it's been my experience and my observations that no task is really that impossible if one applies enough and copious amounts of technology to try and solve it. Thank you for your attention.
Thank you very much. That was fascinating. I think, will you take some questions, Susan?
Yes, certainly.
I think, let's see, Yvette, we have some microphones, right?
Yvette's behind, I think.
To make sure. We need the microphones. Yeah. We need them. Oh, there she is. You got the microphone. Okay. I'm happy to take questions. Steve Connolly. Hey, it'd be good to introduce yourselves because Susan's going to be here for a little while. So I think Steve Connolly.
Hi, great talk. It was very exciting. I'm in both electrical engineering and BioE, and our group is very fascinated with this sort of work, and we're working on adjacent technology. One question is, in the surgical suite, usually you would have an X-ray fluoro unit standing by. I didn't see it in some of your pictures, so could you speak to what is the role of fluoro, and does it get in the way of the robot, and how do you deal with that?
That's an expert in imaging, huh?
Yeah. Absolutely. The fluoro system is there. That particular robotic suite was OR10 at the Mount Elizabeth in Singapore. But since then, the suite has been upgraded to another suite, and we definitely do use fluoroscopy a lot. So yes, it's important. It does not get in the way of the robot. It's a necessary component.
So you can move it over the patient and move it back without having to worry about the robot.
Yes.
That's great.
Yes.
Rujna. Okay, you do. So, do you have a question? Okay.
For the webcast viewers.
Yeah. Please wait till we can.
Rujna Baichi from EECS. One thing that I was missing in your talk, which is wonderful, especially the future, is calibration. So one thing that struck me, for example, I teach robotics, and struck me when you talked about that nominally the surgeons use the table that they move up and down and all that. That can be done if we have real-time calibration, because you can always, as you move, you can adjust the coordinate system and all the respective things. So that can be done rather. Real-time calibration is a little bit a problem, but it can be done.
That would be so useful. That would be really amazing. And I think
to me afterwards.
Exactly. That would be a real gift to surgeons. That would be very useful.
And Steve and Carl right after that.
Thank you again for a terrific talk.
Introduction.
Steve DeMello, Director of Healthcare at Citrus. Question is, how important do you see and how do you see the near-term development of telerobotics as opposed to conventional robotic surgery?
Right. You said telerobotics.
Tele, yeah.
Yeah. Personally, I was really I was really sad to see telesurgery phased out with when Computer Motion Industries was taken over by Intuitive Surgical. I had spent quite a lot of time training at Santa Barbara with the team, and in fact we were really all set to perform a telesurgical procedure between Shanghai and Singapore, and we had worked quite hard on the project. And after Jacques Marescot had performed the first transatlantic robotic procedure, there was another surgeon, Mehran Anvari, you may have heard of him, who conducted a program in Canada. And what he did was he conducted at least, I think, over 30 robotic surgeries, helping surgeons in a district hospital in a remote part of Canada by cooperating with the surgeon in the more remote part of Canada. So to answer your question, I see the role of telerobotics as being able to telementor and to help surgeons because as we become more sophisticated in the technology, there will be issues, and it's always very good to be able to dial back to base and get some expert to opine on a particular step or a particular procedure. It would be really nice from a surgical point of view to see the telerobotic platform being reintroduced.
Carl.
Carl Hedrick, Mechanical Engineering. Most of the applications we saw today were soft tissue related. Is robotic surgery being used much in joint replacement and bone surgery?
Yes. So, very good point. So, the robotic system, the Da Vinci, is currently the preferred robotic system for use in soft tissue surgery. But there are other robotic systems for use in neurosurgery and orthopedic surgery. And I haven't talked about those, but yes, there are such systems. Particularly my colleagues, the neurosurgeons and the orthopedic surgeons, use a different system. Any other questions?
Okay.
Thank you for an interesting talk, especially the timeline, the initial timeline, to see such major changes occurring over a fraction of a career.
That's right.
It bodes well for the future.
Please introduce yourself also.
I'm Alec Dare Abrams, Connexus. My question has to do with the examples that you showed were single surgeons, two manipulators controlled by that surgeon, single point of view, maybe no processing of the imagery, just visible light, a single light source perhaps. What challenges and opportunities are and what exists now in terms of multiple surgeons, multiple controllers?
Right. So Da Vinci, of course, does have an update to the system that I showed you, where there are two consoles and two surgeons cooperating together, which actually simulates a real-life situation in open surgery. I think there's no surgeon that would not operate without an assistant surgeon. It is a very expensive innovation to have another console. Not only that, it also takes up a lot of space. But that aside, I think it would be definitely useful to have the whole team and not just the surgeon immersed in the operative field so as to enable virtual interaction. And of course, as you have said, a lot of improvement does need to be done to the system. It can only make visualization better for the surgeon and the team. And if visualization is better, then obviously the surgeon will see better and hopefully perform surgery much better with a better patient outcome. So all of your suggestions are very, very good. And we'd like to see it implemented.
Let me ask you, I said this morning's San Francisco Chronicle is Paul Wong. So he, just to tell everybody, those who probably didn't read this, there was, and also, by the way, Susan is also a transplant surgeon. She's one of the world's best liver transplant surgeons, which I didn't mention in the introduction. So in this article today, it was a lot about sort of 3D printing of organs. And, so there's this point of view being put forward that as you also got an interest in stem cells and so on. So the point of view being put out there was really you prototype the organ and then you put it in and you then put it in robotically. And it was really a fantastic vision of, so you're in the thick of all of this. So would that be something, students in engineering come and they want 3D prototyping?
No, it's really, Dean Sastry, exactly as how you put it. Because what we would envisage is ultimately replacing organs, not just with transplants, but with bioengineered substitutes. So with 3D printing, I would envisage, for example, introducing a scaffold, having a scaffold being introduced through one of the robotic parts that then just unfolds, and then you seed the scaffold with stem cells. And that could be possible.
Yeah. One more, please.
My name is Avidesh. I'm from mechanical engineering, and my question is about the education and training for these systems, because surgeons are trained for many, many years to be able to carry out operations by their own hands, and I guess working with a system like this is pretty much a different experience. So how long does it take to get accustomed to working with a system like this? And on the other hand, is it already implemented in medical school programs in the education to get accustomed to these? And if not, when is it going to happen? Because if it's the near future, then I guess it would be necessary quite soon.
Yeah, I mean, those are really, really real challenges. Fortunately or unfortunately, we still do have a generation of surgeons who have not trained on robotic systems. And there is still a little bit of inertia, I would say, to embrace robotic technology. As you can see, the timeline, it's only been since 2000 that robotics has been brought on, so we're just a decade and a half into the technology. And no, robotic surgery is not on the curriculum for undergraduate training as far as I know. But having said that, I think it is really, really important for a surgeon still to have grounding in open surgery and in laparoscopic surgery. And then to have as advanced training robotic surgery. Because at any one time there may need to be a conversion from one to the other. And so it's always very important to have all of that in the training. But granted, with the robotic surgical platforms, I think that more and more emphasis will have to be made training the surgeon in engineering. I really regret, in my career, I really regret not having had exposure to computer science and engineering, because for me, I'm more of an entrepreneurial type of surgeon. I see problems. I am frustrated because sometimes I cannot solve them. And if I could do it again, I would have loved to have been an engineer and a surgeon, and I think that would be the ultimate combination.
I am just a community member. But what's the long-term impact on the finances of our medical world in the United States when this becomes more widespread?
Yeah, I mean, that's a very relevant question. Like any new technology, as technology rolls out, it is very expensive. But once it becomes mainstream, hopefully the prices go down. I mean, there has been this huge debate recently in the field of gynecology where surgeons are using robotic surgery to perform, well, I wouldn't say simple, but to perform hysterectomies, which would otherwise be performed just as easily using a laparoscopic or an open technique. And there's this ongoing debate. I mean, robotic surgeons like myself would say, of course, there are advantages with robotic surgery, but if you put in the cost-benefit ratio, it's seemingly difficult to justify at this point in time.
Well, of course, between open surgery and laparoscopic surgery, the one benefit is the reduced hospital stay time.
Right.
And those are gigantic just in the cost of stay and cost of days out of work. That, in 2000, that was already, that was a subject of debate. So that has been crossed. But now I think from laparoscopic to robotic, certainly everything that Susan said is interesting, but then we had a baby a few months ago, and then the surgeon that delivered it, she said that actually the training and credentialing of people using robotic procedures is actually also a savings in terms of training. So in terms of working out how that actually brings down costs, it has to be amortized against, I think, the cost of the instrument. The current cost of the instruments are high, and this is one of the reasons that Susan's a visiting scholar here, because I think the premise is that there's no reason we can't ride that cost curve down in terms of, it's $1.5 million, is that right, for the Da Vinci? So if it was smaller, perhaps it would be an order or two magnitude cheaper. And so, sorry, this is your.
Those are absolutely correct.
There could be manpower savings and less time and so forth involved in the actual surgery.
I think I agree with you. Manpower savings, absolutely, because I think eventually robotics is going to complement the human race. I mean, you just have to look at Japan, the way they are embracing robotics in almost every dimension of life. That we just have to embrace robotics, and you are right, absolutely, that robotics is going to lead to tremendous cost savings in terms of manpower. And with time, I suppose, it will also become easier to perform surgeries robotically.
Okay, should we make this the last question? Is that you right? Oh, Chris, one minute. Okay, good.
I'm a visitor here. I've come from India, and I was pleased to see this talk and just dropped in with almost no notice. I just wanted to know from a training perspective that this kind of procedures, if you wish to carry out, simulator-based training is something which you use often in other fields. How effective has it been in real life for robotic surgery? Are there simulator-based training which can give as good effect, where you can go from a simulator into real-life operations?
Well, I think especially with robotic systems, it is really very, very much easier to train because, you can have a robotic system like this in the lab and you can practice for endless hours. Suturing, it's a good point. For all of us surgeons, we practice from inanimates to working on animals with robotic systems and then moving into patients. But your point is taken, and really the robotic surgical platform will soon be able to superimpose, for example, a CT scan or a pre-operative image of the patient onto the real-time operative field. And so before even making a cut, the surgeon may be able to rehearse and plan the operative procedures. But yes, it makes it much easier to train.
Let's have Chris make the last question. No, to make it good, Chris. You sure?
Here we go.
Okay, you'll have a chance to talk to him. Okay.
Yeah, hi, my name's Henry. I'm just wondering how would robotics affect the future of dental surgery?
Yeah, let me just switch and move up. Robotic surgery has been used in oral facial maxillary surgery. Robotics, now that's a good point I failed to bring up, doesn't need to be used just within an enclosed cavity. Robotics can be swung on even in open surgeries. So for example, if you have an abdomen open and then there's a little bit that you want to do robotically, like suturing, you can swing in the robot. So likewise in facial oral maxillary surgery, I think robotics, so long as the instrumentation is available, could be very useful. I'm not sure, I'm not a dental surgeon, but I could see that it would be useful.
I'd read something about this cleft palates being done robotically. It's not quite dental surgery, but
that's right, maxillofacial surgery. Yes.
All right. Well, let me just sort of plug a little bit about why Susan's here and why. So Susan is as she said, an entrepreneurial surgeon. It's wonderful to have a surgeon who's constantly pushing us, technologists, to really do more. And she is willing to go try it out in the operating room, subject to approvals, etc. So let me say this properly. But she will be here with us, and she would like to challenge all of us to really sort of think about taking the next step and really sort of pushing this technology even further. So she'll be here off and on for varying periods during the course of this year. And we're hoping, and I see a lot of people here we can have really sort of substantive interactions. Robotic surgery is certainly close to my heart, but what Susan's telling us is, let's sort of take a look at where we are today, and let's sort of take it to the next step, and bring in cost considerations, drive down the cost, make things smaller, make things more easy to use, and then combine them with regenerative therapies, like the stem cell therapies. And this, I think, is a wonderful program, and I'd like to thank you for bringing these opportunities to us. So thank you very much.
Thank you.
The last thing, a humorous note, I was just thinking as you were showing these pictures that I'm hoping everybody was enjoying their lunch. So thank you very much.